And Munir is going to tell us how to do a repair of asymmetric bicuspid aortic valve.
Thank you. First of all, thanks, Mural and Dr. Adams for the invitation to present. It's really a privilege to be here. Before I get started talking about bicuspid aortic valves, just wanted to say a quick word. I don't know if Dr. David remembers this, but when I was in training, I had the privilege of getting the ATS Resident Traveling Fellowship that used to exist at that time, and I remember spending a week with him, and in that week I saw a flurry of mitral valve operations. I saw a commando procedure with mitral annular decalcification, saw a bunch of valve sparing, and it was really a very impactful week. But one of the things I told him, standing at the head of the bed was, oh, I'm thinking about going to work with Jibreen for a fellowship. And he was very proud and very quick to tell me, oh yeah, I trained that guy. So, so I guess I had a nod of approval. Now, when mentorship is so important in surgery and in many things, and we often think of our mentors as like a parent figure, father figure in my case. And if we take that analogy forward, I guess Dr. David would be like a grandfather figure to me, but no pun on the age. Finally, I think it's really nice to see the community that's being built around this. I think it's so gratifying to work with the colleagues around this room who are so focused on technical excellence. So thank you for all that and all those legacies. All right, bicuspid aortic valves. So, I think we all recognize and have recognized for a long time that bicuspid aortic valve is not one entity, that it consists of multiple different phenotypes of expression. And the lesson for me was back in 2010, I was looking at a series of bicuspid aortic valve repairs that Jibreen had done. And at that time, we didn't have vocabulary to talk about the different types of bicuspid aortic valves that we had. We had the Sievers classification that told us either you have a RAFE or you don't have a RAFE, type 0 or type 1. But when we looked further at the thinking behind repair, we realized that there's type 1 valves that have prolapsing excess leaflet tissue. We used to call it back in the day prolapsing RAFE. And then we had some that had a very restrictive RAFE. And the patterns of aortic insufficiency were very different in that population. And in reality, we realized that it's actually a wide spectrum between these. But we really didn't have the vocabulary to talk about it. And many years later, Laurent published this paper. It's a multi-center series where we were able to actually characterize the relationship of bicuspid aortic valve commissure orientation with other parameters of bicuspid aortic valve. And I think it's important to understand this to determine what type of bicuspid aortic valve repair we need to do. So on one hand, you have a symmetric or near symmetric bicuspid aortic valve, which has a commissure orientation between 160 and 180. Those valves have a very low pseudo-commissural height, and they have a very long RAFE. Type B, asymmetric valve, have a more asymmetric orientation, 140 to 160, a higher pseudo-commissure height, and a shorter RAFE. And similarly, along that line, you have the very asymmetric valve. Now, if you were to go to the right of this figure, which doesn't really exist, what you would have is a tri-leaflet aortic valve. Completely symmetric, 120, 120, 120, with a very tall height of the true commissure and no RAFE. And on the left of that figure would be a true type 0 valve. So it gives us the true spectrum of entities that we have between a Sievers 0 all the way to a tri-leaflet aortic valve. I think the principle to realize is that the symmetry or asymmetry for bicuspid aortic valve exists at various levels. It's not simply a sinotubular junction issue, it's also a ventricular aortic junction issue as well as the line of leaflet insertion. So when we talk about a bicuspid aortic valve repair that's a type 0, our objective is to get perhaps uniform downsizing of the annulus. But when we do a reimplantation procedure in a type 1 bicuspid aortic valve, we're actually doing an asymmetric annuloplasty and restoring the ventricular aortic junction level to a symmetric VAJ. And understanding that concept impacts how you address the cusps. So I think that's something to lay out. This is the slide that probably summarizes the main message from this talk, which is that when you're trying to look at a bicuspid aortic valve along that spectrum of geometry, your goals are to maximize mobility of the non-fused cusp, number one, optimize effective height of the fused cusp, and finally, to the extent possible, preserve the mobility also of the fused cusp, and that'll determine longevity. So practically speaking, what options do we have in terms of symmetry to repair bicuspid valves? Well, if you start off with a symmetric valve, I think the answer is simple. You leave it symmetric. If you start off with an asymmetric valve, you have an option. You can either make it symmetric, or you can leave it asymmetric. The concept here is that leaflet mobility and leaflet effective height is a function of intercommissural distance, something that Laurent mentioned, as well as the free margin length. And so we have the ability, by choosing symmetry or asymmetry, to adjust that interleaflet intercommissural distance. And then finally, if you have a very asymmetric valve, these are the most complicated valves to repair. Fortunately, they're only about 17% of the entire cohort of valves presenting for repair. Those could be either reconstructed symmetric, or they could be tricuspidized with a 120, 120, 120 orientation. However, that typically requires patch material. The biggest conversation or controversy sometimes comes into this type B group, which is, do you reconstruct these symmetric or asymmetric? And I would say there are some factors listed there that might help. If you have significant aortic insufficiency, if you have restriction of the conjoint cusp, if you have a calcified raphe, or if you have a short geometric height of the raphe, all those are reasons to perform a symmetric reconstruction so that you have added mobility of the conjoint cusp, and then you can use that to get a more durable repair. On the other hand, if you're operating on an individual with predominant aneurysm as the indication, no real AI or minimal AI with mobile cusps, and they happen to start off with an asymmetric valve, you can walk out with an asymmetric valve with just as good a result. One note, we don't have a lot of data on post-repair commissural orientation and outcome except for this study. This is by Joachim Schaefer's. This is not a reimplantation population, so 30% of these patients had a subcommissural annuloplasty. Some of them had no root intervention. But one of the messages, one of the signals was that if you leave behind an asymmetric valve with the commissural angle greater than or equal to 160, you have a higher risk of recurrence over time. So general approach to bicuspid aortic valve repair, I would say for me is, number one, address any deal breaker abnormalities, so any calcification, thickening, perforations, fenestrations, to determine whether you're going to be able to repair this valve. Number two, manage your raphe, releasing of the raphe, shaving or mobilization. Then you perform your annular and root maneuvers, which often ends up being a reimplantation procedure, and do your final cusp correction at the end once your annular geometry has been fixed. So I'll show a couple of videos that hopefully demonstrate some of these things. On the left side is the assessment of this bicuspid aortic valve, and on the right side, you'll see us using some of the techniques. So this is a valve that's quite mobile. It's got two well-moving leaflets. There's some annular and root dilatation, but there is, in the anterior part of the conjoint cusp, an area of thickening and a bit of calcification. And so this gives me pause to say, can we repair this valve? Is it reasonable to repair this valve? And so we start by this technique first. And our approach, like we've seen many times, even in the mitral sessions, is a parsimonious resection of the leaflet, enough to remove the pathology, but not too aggressive to actually damage normal tissue. And a preferred method here for me is a sharp dissection with a number 11 blade. And you can see often that the calcium can be removed, almost enucleated from the leaflet, while leaving behind adequate quality leaflet tissue. And so after you do this maneuver, if you judge the mobility to be adequate, and 95% of this valve is essentially normal with only this one lesion, then you move on to the next steps of this operation. I'm going to show you one other case. It's a little bit more complete. So this is I would say, an asymmetric bicuspid aortic valve, not a very asymmetric, but it's an asymmetric. But the raphe certainly has a good amount of calcium in it. Even the non-conjoint cusp has a little bit of calcium in it. And so one has to deal with that first to determine whether this valve is repairable or not. Now, it's important to note that the non-conjoint cusp is quite mobile. It has an adequate geometric height, here measured at about 25 millimeters, 20 being the cutoff for acceptability. But you see a good amount of thickening and calcification of the conjoint cusp. So this is one where you don't have a lot of conjoint usable cusp. A symmetric repair is going to help you to gain that mobility on the conjoint cusp. The way I would deal with this is by placing a retraction suture on that thickened tissue, and then again a sharp dissection of that raphe region. Remembering that we're losing some of this cusp, but most of this will get ultimately plicated away, and it won't be part of the ultimate coaptation surface of this valve. On the non-conjoint side, there's thickening. Here we're doing a shaving to basically enable better and smoother coaptation between the two leaflets. You see now that the leaflet has become quite mobile. We then do a raphe release, and this release again adds to the mobility of the leaflet and actually improves the geometric height at the level of the raphe. This is a 180-180 implant, so exactly opposite from the non-left commissure is where we put the right non-commissure, which is a small indentation is made. I haven't gone through the external dissection here because you've seen this already, but we then parachute this Valsalva graft down. We do check effective height of the non-conjoint cusp to make sure that we're leaving behind an adequate height valve. And then once you're happy with that, you can use that as your reference cusp and oppose the conjoint cusp to your reference cusp. It's important to pull on your reference leaflet to be able to really have those sutures line up. Once you've determined this, you carry the same plication into the body of the leaflet for 2 or 3 sutures, and now you have 2 symmetric valve leaflets that have a good amount of coaptation surface area between them. I'll give you one other example, slightly different. Here, again, a mildly asymmetric valve, not a very asymmetric. You can see that the anterior cusp is pulled away a little bit from the posterior cusp. And in order to actually enable better coaptation, you need that selective annuloplasty of the muscular portion or the anterior portion of the annulus. So we assessed this cusp again for its mobility. This one had a very small amount of calcium at the tip. But, and you can see the thinning of the cusp of the root there. We've performed our external dissection. We've placed our proximal sutures here. And once the graft, again, 180-180 implantation, once the graft goes around, you'll see a lot more mobility of this conjoint cusp. It's prolapsing a lot more now, but there's a lot more give to it, giving us the ability to reapproximate the two. In this case, we felt that the effective height of the non-fused cusp was inadequate, so we did put a plication stitch to raise it, and then again, we used that as our reference to repair the conjoint cusp. And once this is done, you'll see that you have 2 mobile cusps, 2 cusps that are where the free margin is parallel, and that there's adequate surface of coaptation between the 2. So my summary would be that cusp symmetry in bicuspid aortic valves is an interesting and useful tool to describe the heterogeneous valve phenotypes that exist in bicuspid aortic valves, that annular interventions are critically linked to facilitating cusp repair. Our goal is to preserve mobility of the non-fused cusp and the fused cusp while obtaining sufficient effective height and coaptation. And symmetric reconstruction gives us an added tool to improve fused cusp mobility, facilitating repair. However, asymmetric reconstruction may be reasonable in bicuspid valves without AI or without significant disease. Thank you for the privilege of presenting. I want to invite people who might be interested in learning more about aortic valve repair to this masterclass course that's happening on September 5th and 6th in Ottawa. It's the North American Aortic Valve Repair Symposium that a group of us put together, and welcome you to attend.
Great. Okay, let's invite